computer. All right, so we are recording right now. So good morning. Today is Saturday, July 19th. Jan, how are you this morning?
I'm well this morning, as we were discussing earlier. It's a cool morning, a little muggy but
Yeah.
cool, so it's delightful. I have all the windows open. I hope the birds don't. I don't know. Can you hear the birds tweeting out there?
I cannot. I
Right.
cannot,
That's good. They won't
unfortunately.
disturb our,
Um,
our listeners. I'm sorry, listener. They won't disturb our listener. I think we
right,
have.
right.
But yeah, it's good.
I will
How
start by saying everyone who reached out, there was about 15 to 20 of you reached out to me personally. I do appreciate the positive feedback and the positive comments. Um, it has so far been a pretty new thing for both of us. We don't know what we're doing, so we're kind of just talking, and that's about it. Anyways, if you're just listening for the first time, my name's Isaiah Hahn. I'm a physician assistant. I work in endocrinology in State College. And with me today is Dr. Jan Ulbrecht. He is an endocrinologist for what, Jan, now 40 years?
Something like that. Yes.
Yeah, long time, almost double my life. So anyways, the first episode, if you didn't listen to it, we talked about hypothyroidism. It's a very introductory kind of thing. So if you want to listen to that, please do. This is the second installment, and in this one, we're going to be talking about hyperthyroidism. So we already talked about basically where the thyroid is, what it does on a basic level. So if you want to know more about that, I would suggest listening to the first episode about the first 20 minutes, and that's pretty much explained. So, Jan, if you want to kick us off here, what is hyperthyroidism? And then we'll kind of branch off into the two big umbrellas of hyperthyroidism and go from there.
Yes, of course. So, as Isaiah mentioned, and as we were discussing, I do want to just reiterate in two or three sentences what the thyroid does, because it does sort of lay the groundwork for discussing hyperthyroidism. And as we discussed in much more detail last time, the thyroid is essentially the cruise control in the body. It tells everything in the body how fast to run. Brain, heart, bowels, kidneys, everything runs at the pace that we think of as normal, completely natural, the way it should be, because the thyroid is telling all these organs how fast to run. And evolutionarily, in other species, there are variations in that over days, over months, over the seasons. In humans, very little. So we typically don't even think about our thyroid because it typically is completely steady. Except, of course, when there is a problem with the thyroid, and as we discussed last time, probably the commonest functional problem with the thyroid is hypothyroidism, underactive thyroid, but hyperthyroidism, overactive thyroid, is also very, very common. And Isaiah, what question did you actually ask me?
Basically, just talking about what is hyperthyroidism, like what are the manifestations, the
Got
signs,
it.
the symptoms, and
Thank,
then we can start branching into the specific things that cause hyperthyroidism and the specific disease types.
thank you. So I'll get this. It's early in the morning yet.
It is, yeah.
So with that background of what the thyroid does normally when the thyroid becomes overactive, a person who has severe and essentially all symptoms, and as we talked about with hypothyroidism, it's actually not unusual to have just one or two symptoms. I've also seen people have completely the opposite symptoms, have no symptoms. So anything's possible. But the classic severe symptoms would be everything speeding up in the body. And so if we think of it again, sort of head to toe, the brain speeds up, and people talk about trouble sleeping, anxiety, can't focus, can't think. Things are happening so fast in the brain that it's very, very difficult to slow down, to be patient, but also to think things through. And at the first visit with somebody with severe hyperthyroidism, we actually don't purposefully discuss more than they want to hear, because it's very hard for people to take in what is being said. So anxiety, trouble sleeping, trouble focusing, trouble thinking, that's the brain part. again, as everything revs up, so as the kidneys rev up, more frequent urination, more frequent bowel movements. People often talk about palpitations, rapid heartbeat, pounding heart, sometimes irregular, but not typically, shortness of breath, and then weakness. If you think just sitting, all the muscles are exercising. Just sitting, everything is happening super fast. So you can actually get actual physical weakness of muscle because it's over revved, overworked. And an odd one that is not super common, but it's certainly something we see, is a weakness of the esophagus, of the swallowing muscles. And people talking about difficulty swallowing because that muscle has gotten weak. As all these things are happening very fast in the body, two other things happen. One is the person can and often will lose weight, and sometimes it's very dramatic. And another is all this activity produces lots of heat. So a person can become very hot, also very exercise intolerant. So already at rest, the heart is working really hard, the lungs are working really hard. So it's very, very difficult to add to that. And particularly elite, or even not even elite athletes will often say, I can't do what I know I can do. There's something really wrong. I know I can run, a 5K and whatever, and I can't even finish. Now, again, coming back to where I started, some people have zero symptoms, oddly enough. Also, the symptoms become less and less obvious as we get older. And so at my age, for instance, people would often be described as having apathetic hyperthyroidism, where the symptoms are primarily just sort of failure to thrive, just feeling blah, and there's something wrong, and losing weight. And that's about it. So everything is fast. Symptoms are much less common as we get older. So I hope that answers that question.
Yeah, no, absolutely. And that's a really good point you brought up about athletes, because I know I've seen a couple of younger athletes for sure who've shown up, with a TSH of 0 and a free T3 of 6 or so, and they kind of talk about this. I've been training for X amount of years and whatever, and I can't even get through a warm up without even bending over, and I'm so short of breath. And also appetite. Some people get a huge appetite upregulation, just because, as you mentioned, everything speeds up. So you tend to run through things pretty quickly.
And thank you for reminding me about that. So sometimes the appetite can actually outpace the energy use. So even though obviously the energy use is markedly increased, the appetite can sometimes outpace that. And sometimes we see people gain weight with hyperthyroidism because they are so ravenous that they're eating all the time. So thank you for reminding me of that one.
Yes, absolutely. And also just arrhythmias. So atrial fibrillation tends to be something that we've definitely seen a lot of with these folks. And there's some very finite specific mechanisms with how T3 kind of pushes all that stuff. Anyways, so we'll kind of go into the testing, which I kind of briefly talked about there. So like Jan had mentioned, it's an overdrive of the thyroid. So the TSH and the free T4 and the free T3, they are the key players in running the show. Do you want to talk about how the relationship of those labs changes in this situation?
Yeah, so in the first episode, we talked a lot about the challenges, the practical and in the laboratory challenges of these tests, and that would apply here as well. The problem with hyperthyroidism is that the sequence matters, and the time point in the sequence of events matters. And we talked a lot about the supremacy, quote unquote, of the TSH, and that we've really been good at teaching all doctors, essentially all healthcare providers, of how important the TSH is. And in the simple scheme of things, the TSH stands for thyroid releasing hormone. I'm sorry, thyroid hormone releasing hormone. And it is made by the brain through the pituitary gland, which is the master gland in the body. And at the simplest level, if the thyroid is producing too much thyroid hormone, then the brain will perceive that and will turn off TSH. So TSH of 0 or very, very low TSH, but typically it's going to be zero, means that the thyroid is producing too much thyroid hormone. And as we discussed last time, a high TSH means the opposite. Now, the problem is that the TSH can sometimes lag, particularly in reverse. So, as we'll talk about later, as the thyroid hormone levels drop, typically because of treatment, the TSH can take even several weeks to come up again. And so, in a dynamic situation where the thyroid hormone levels change, either because of treatment or because of thyroiditis, which we'll talk about in a little bit, that TSH is really pretty much useless. And this is a very important piece of the puzzle for healthcare providers.
Right. And that's where the T3 and T4 actually come into play. And they're much more valuable in this case than they are when you're just checking someone you think has hypothyroidism or someone with normal thyroid function, because the TSH suppression is a spectrum. I mean, we've seen people with a TSH of 0 and their free T3 could be anywhere from 4 to 20. So, like you said, the TSH of 0, it doesn't really tell you anything.
That's a really important point. Yeah, thank you for reminding me. And the point you just made was really important. I was talking about the delay in the TSH recovery from being suppressed, right? So you can actually have low thyroid levels and symptoms of hypothyroidism, but the TSH may take a while to come back. And so you misinterpret that. What you're talking about is the severity of hyperthyroidism. Right. And at least from the biochemical, from the testing perspective, and the TSH is going to be 0, whether the thyroid level is twice normal or 10 times normal, it's going to be 0. So absolutely. Again, thank you for bringing that to us.
Right. Okay, so we're going to start talking about the specific things that cause hyperthyroidism in particular. So if you're listening to this and you're not watching, imagine you take hyperthyroidism and then you take an arrow and you go to the right, and you take an arrow and you go to the left. So we're going to go to the right first, and we'll talk about something that's called destructive hyperthyroidism. So there's two kind of main causes of destructive hyperthyroidism. Do you want to kind of branch off into that and start with whatever you want, viral, autoimmune?
Yeah, so the underlying concept is that the thyroid actually does not overproduce thyroid hormone. It simply releases all the pre-stored thyroid hormone. And there's a lot of pre-stored thyroid hormone in the thyroid. And if that is released suddenly, it can cause very high levels and very symptomatic, be very symptomatic in terms of hyperthyroidism. And it can last a while, again, because of there is so much thyroid hormone in the thyroid. So it can last several weeks. The overactive phase of as you refer to it, destructive hyperthyroidism. There are a couple of basic reasons why the thyroid cells can get damaged and cause these high levels in hyperthyroidism. And again, as you said, one is viral and one is autoimmune. Let's talk about viral first, because it's a little more straightforward. Basically, this is a viral infection of the thyroid, essentially. It is almost always associated with some other viral infection, and often will be preceded by the viral infection by several weeks. So in the classic case, someone will remember having sore throat or something like that, and it typically is a respiratory thing, 2-3 weeks earlier, and is sort of recovered from that, but then isn't feeling well, begins to develop symptoms of hyperthyroidism. And that is classically associated with severe pain in the thyroid. We talked the last time, the thyroid is a butterfly-like gland that wraps around the lower part of the neck, in the lower part of the neck. Mm-hmm. And again, in severe cases, the thing that we're taught in medical school, you can take a feather and touch that neck, and it's going to be excruciatingly painful. Obviously, like most things, there's a lot of variability. And we see very mild, very significant hyperthyroidism, but not very much pain. This is also associated with systemic symptoms. Again, it's a viral process. So people often have fevers and can just feel pretty miserable with that. It's a self-limited illness, as everyone knows, I'm sure. There's no really great way to treat viruses. And so as far as treating the underlying disease, there is not much to do, but fortunately it is self-limited. It will usually, the tenderness will, and the symptoms of hyperthyroidism will resolve over several weeks. As we've said several times, the variability is the name of the game in medicine, right? So we've seen people who have localized tenderness in one part of the thyroid, and it sort of marches across the neck, and then that can take several weeks or even several months with mild hyperthyroidism, and it acts as if it appears as if the thyroid infection sort of progresses slowly from side to side. So there's a lot of variability.
Mm-hmm.
When the pain is severe, anti-inflammatory agents can be quite helpful, and the most, of course, i.e. Motrin, those kinds of things. But in the most extreme situations, we will use the anti-inflammatory properties of steroids, prednisone, and that can be super helpful. And then the symptoms of hyperthyroidism can be counteracted with beta blockers. Everyone knows propranolol, and that's very effective at that. So we haven't talked about diagnosis. Maybe we can do that in a minute. But once that disease is diagnosed, that's the treatment.
Okay. Yeah, and just to kind of rehash that for anyone who might have not understood, on a very simple level, when you get sick with a virus, it could be one of many viruses, they can tend to kind of quote unquote make the thyroid cells lyse or be destroyed or kind of quote unquote explode. And obviously within the thyroid cells is thyroid hormone. So if you have these cells bursting, a lot of them, thousands, millions of them, you have all of this, you have this huge surge of thyroid hormone in the blood, and eventually will taper off because nothing's kind of stimulating it to keep doing that. That's why it's called destructive. It's destroying the cells. And then, yeah, and then do you want to talk about diagnoses of that? I mean, you already talked about the signs and symptoms, and it's pretty much a clinical diagnosis at that point.
Yeah, so when it's obvious, it's usually pretty obvious. But the key distinction is to make the differential diagnosis from productive hyperthyroidism, and we'll talk a lot more about that because that's a lot more common. And there's a couple of different ways of making that distinction. There's a blood test, and we'll talk about that for productive hyperthyroidism. If that's positive, that's pretty clearly the diagnosis. A more sort of an intuitively obvious way to make the distinction is to look at what the thyroid is doing. So in productive hyperthyroidism, the thyroid is going to be very, very active, making lots and lots of thyroid hormone. In destructive hyperthyroidism, it's not making any. It's zero. And there's a test called thyroid uptake, which we usually link with another test called thyroid scan. And they're very, very old, very, very straightforward, very simple tests that radiology can do for us. Nuclear medicine tests is not a whole conversation, but basically they rely on the uses of tiny amounts of radioactive materials, very, very safe, and to scan different parts of the body. And in this particular case, we look at the uptake of the radioactive substance in the thyroid, and it's going to be zero when the thyroid is inactive, and very, very high when there is productive hyperthyroidism. So that's a test that we'll often do.
Yeah, too. And I know many times I've actually seen patients myself where, for whatever reason, they didn't get there until maybe 3, 4 weeks later, and their TSH was zero, but now we measure it again and it's 1, and it's starting to rebound a bit. So most of those people do, as Dr. Ulbrecht mentioned, self-limiting disease, and it tends to resolve for most people on its own. Now, if we go into autoimmune destructive, if you want to take the floor for that.
I'm just going to say one more comment about the viral, and that is that the thyroid almost always heals. Surprisingly enough, as I just described, these cells bursting, you would think that that would be pretty much the end of the thyroid, but it's not, and it typically recovers. So it's very, very unusual to develop a permanently underactive thyroid as a consequence of these thyroid infections. And to the earlier point, when you said you see patients a few weeks out where the TSH is already rebounding, again, the TSH may still be zero at that point, but the thyroid hormone levels can already be very low, and it has to happen first before the TSH can rebound. So by the time the TSH is rebounding, the person will actually typically have symptoms of an underactive thyroid, which is what's driving the rebound of the TSH. So it can get a little complicated. Now, the autoimmune version of this disease, it has the same exact time course and same exact sequence of events. It can be fairly severe in terms of symptoms, but it almost never is associated with pain in the thyroid. Never say never in medicine, it can, but it's never as severe. And if there is pain, it's mild and usually quite tolerable, and maybe a couple of Motrin to take care of it. There is no prodrome. There's no viral illness or anything like that. It just happens out of the blue. And as we discussed last time, most thyroid disease is autoimmune, and I think we discussed autoimmunity last time a little bit as well, so I'm not going to get into that. But in essence, the immune system attacks self. And this is intuitively fairly straightforward, right? The immune system is supposed to, in its normal function, attack and destroy cells, foreign cells. In this case, it attacks native cells with, again, the very similar pattern in terms of the up and down of the thyroid hormone levels and so forth. Now, this is again self-limited. There's again not much to be done about this. The propranolol to suppress the symptoms of hyperthyroidism is again a reasonable option in people who need it. The time course is very similar, several weeks. But here the recovery is, I would say, almost never complete. Yes, there are people who have this where 3 months out, 4 months out, they have completely recovered. But as we discussed last time, even a TSH that's in the high reference range is probably not where they started, and we don't know where they started, but it's pretty common to end up with TSH levels of 2 or 3, and perhaps without symptoms. But again, as we discussed, that implies that the thyroid is struggling to work normally. And in a significant number of patients who have this disease, the thyroid actually does end up symptomatically failing with higher TSH levels. And the person ends up permanently hypothyroid and treated as we discussed last time. This disease can be recurrent. So the viral illness we talked about, it would be bad luck to get the same type of virus again, but it can happen. With this disease, with the autoimmune disease, again, as we discussed last time, the autoimmunity does wax and wane, but it is typically recurrent and progressive. So this disease often will recur over a number of years even. And a particularly frequent time for this to happen is after giving birth. So women who had a child in the previous 6 months or so, typically 3 months, will often have this problem. And in that situation, it's called postpartum thyroiditis, even though it's exactly the same thing.
Yep. And just to rehash some of the antibodies that we briefly touched last time, the main ones are TPO, which is thyroid peroxidase, which is an enzyme within thyroid follicles that actually aids in the process of producing thyroid hormone, and thyroglobulin antibodies as well. Thyroglobulin is a protein that acts to couple thyroid hormones and also aids in the synthesis of thyroid hormone. Okay, now Do you want to start moving into the productive side? Okay. So just to rehash, hyperthyroidism on the right, we have destructive, viral, autoimmune, viral, typically a painful neck, not always, but most times, and autoimmune, not typically any pain, and then the typical laboratory findings of that. And we go to the left, we have productive, which is probably one of my personal favorite things to learn about early on. So we'll talk about Graves' disease first. Do you want to start that off? I guess technically, what is Dr. Grave, was that was his name? That was what it was.
I
Yeah.
think so. I think so. So in medicine, many things that have been described, 100 or more years ago, are associated with physician's name. Um, and I actually knew one of these doctors. He was still practicing when I was in training in Syracuse, Dr. Sipple, and hence Sipple syndrome, which is a whole different thing that we're not going to talk about today. But it is a thing. I did not know Dr. Graves or Grave, but he was the first to describe this typical form of hyperthyroidism. And again, in the classic form, and when diseases are first described, they described that they're typically observed in the severe forms because it's pretty obvious, and then we recognize that there are less severe versions of the same thing. But uh, what was described then was the severe symptoms of hyperthyroidism that we talked about earlier. In any case, this is an autoimmune illness, and we talked last time about antibodies and other aspects, other processes within the autoimmune family, damaging the thyroid and causing hypothyroidism, underactive thyroid. This is a little quirkier. The immune system is not always perfect, and this is a good example of it. Again, why the thyroid is such a common target of autoimmunity is not completely clear. But what happens in this disease is that the immune system produces antibodies, which are sort of key and lock chemicals that are very, very specific to a specific protein target, to a specific target, typically on the cell wall, but it can be in other places as well. And so the antibodies produced, there are others as well in this disease, but the key antibody produced in this disease is TSH receptor binding antibody. And so the key, if you like, is the antibody. The lock is the receptor on the thyroid cells. Now, TSH receptors, or receptors in general, are responsible for receiving the message and doing something with it in the cell. So you can think of the TSH receptor as the on-off switch on the surface of the thyroid cells. And TSH normally arrives and turns these receptors, these switches on, which is how the thyroid functions. In this case, these antibodies come along, bind the receptors, and erroneously turn them on. And so the thyroid doesn't know any better. It's getting the message that all the cells should work at full capacity, and they do. And hence productive hyperthyroidism. And as we discussed earlier, if you look at the activity of the thyroid in this disease, it's going to be super active because it's turned on full blast, trying to make all the thyroid hormone that it can.
Yeah. And interestingly, I think this is the only autoimmune disease that causes up regulation of something rather than destroying or down regulation of something. But I'm sure I might be not correct about that. I thought I had seen.
Actually, no. So another one that comes to mind, and this is again in the field of endocrinology. I suspect there are others in other fields that I don't know about. But in the field of endocrinology, you can have hypoglycemia, low blood sugar, from antibodies that stimulate the insulin receptor. Not very common, very, very rare, in fact, but it can happen. Same exact process. The antibodies bind the insulin receptor and turn it on. So yeah, it does happen.
So in this case, just to rehash, we have your immune system for, one of many genetic, environmental, whatever reasons, is making antibodies that signal the thyroid cells to keep making thyroid hormone. So it's not regulated in any way. And like Jan mentioned, it kind of just mass produces thyroid hormone, but it can wax and wane too. It can't always be consistent. And there can also be blocking antibodies as well, the TSH receptor stimulating antibody and the TSH blocking antibodies. Do you want to talk a little bit about the specific manifestations of Graves'? So this is Graves' disease again, of Graves' disease.
Yeah, so there's a couple of peculiarities about Graves' disease. Before I go on with that, thank you for reminding me about the TSH receptor blocking antibodies. And I think we talked about these a little bit in the past, at the last episode. I'm not sure.
Yes, briefly.
Yeah, that can cause an underactive thyroid that's self-reversible, and it's difficult to figure out when it might reverse. But the other thing is, and I'm not sure we talked about this, the antibody function can flip-flop. So we do see a fair number of people who have hypothyroidism, and then they change into this productive hyperthyroidism. And this was completely unheard of when I first got into medicine back in the 1980s, but it's becoming quite common now, and I don't know that we know why that is. In any case, it can be quite confusing, of course, to patients and healthcare providers when they're treating somebody for hypothyroidism and all of a sudden they become hyperthyroid. Regardless, the additional manifestations of Graves' disease. So the big one is the eye disease. And this is a peculiarity of, it's typically seen in the autoimmune hyperthyroid thyroid disease, but it can also be seen occasionally in the autoimmune hypothyroid disease. And you may remember the hypothyroid is called Hashimoto's thyroiditis because of Dr. Hashimoto. The overactive is called Graves' disease because Dr. Graves. And it makes no sense if you think about the names that in fact they're essentially the same disease, but enough of that. There could be other antibodies produced that are directed against the thyroid, but coincidentally also seem to bind tissue behind the eyes. And again, that's one of those peculiarities of biology. I mean, why would that be? No idea. But when these antibodies are produced that bind the tissues behind the eyes, a person can get a variety of eye symptoms, and that's called Graves' ophthalmopathy or Graves' orbitopathy. And the mildest, it's going to be some irritation, some redness of the eyes, some particularly in the morning, some discharge from the eyes, that kind of thing. In the more severe, the eyes can begin to bulge, be pushed out by inflammation behind the eyes. You can get inflammation of the muscles that move the eyes around. When we look left and right, that's actually muscles pulling on the eyeball left and right to look left and right or up or down. They can become inflamed and swollen and not function. So a person can have double vision, bulging eyes, and in the very extreme, which is very unusual, you can actually experience vision loss. Now, this is becoming quite rare, and apparently it seems to be associated with a decrease in smoking. Oddly enough, cigarette smokers are much more prone to develop this problem than people who don't smoke. Secondhand smoke can do it. So we don't see this very much anymore, fortunately. There's a variety of treatments that are available, and again, nobody will ever experience blindness from this because there are treatments. There are treatments that are specific to dealing with the antibodies. There are more generic treatments, such as, again, prednisone, steroids, and even radiation. So it can be treated, but it can be quite troublesome if it occurs. The other much less common associated problems, and again, it's probably the same idea. It's probably some antibody causing what's called pretibial myxedema, which is a very characteristic skin rash on the lower leg. That's even less common and often missed because it often doesn't really cause too much trouble. but the eye disease is the big one.
Yeah, absolutely. Anything else that you want to add to Graves' disease at all?
Well, I think in terms of causation and so forth, not really. I think we do need to talk about treatment, which is a big topic. But if you're ready to go on to that, then I think we should.
Yeah, absolutely. Go for it. Go ahead.
Yeah. So treatment of productive hyperthyroidism, and this particular version of productive hyperthyroidism, the autoimmune TSH receptor stimulating or Graves' disease, is somewhat tricky. And that is primarily because we don't have or choose not to use immune system modulation treatments, right? So as people probably know, we have lots of medications that so essentially suppress the immune system that we do use in diseases like multiple sclerosis and rheumatoid arthritis and so on, where we don't really have any other options. Um, in general, they're considered a sledgehammer approach. In other words, an overkill for the thyroid. So what we do with the thyroid is treat the thyroid, even though the real problem is the immune system. And the classic place to start is to block down the thyroid function. So the receptor stimulating antibodies are stimulating, and there's a couple of medications that are older than I am, believe it or not, that we use to suppress the thyroid. The one that we used to use way back quite a lot is it's called propylthiouracil, which we abbreviate by PTU, much easier to say. The newer, not so much newer, but same age, but the one that we use a lot more now is called methimazole. And they work exactly the same way. They essentially suppress the thyroid function. And so the immune system is stimulating these medications, suppress, and the result is some of the balance, if it's achieved correctly, is a normal thyroid level. Now, that is a trick with both of these medications, in that, as you mentioned, and I think as we talked about last time, the immune process waxes and wanes. And so the degree and the severity of the hyperthyroidism can wax and wane typically over weeks and months or years. And so we do need to keep adjusting the anti-thyroid medications to match the degree of overactivity. But as long as that is done, and it does require fairly frequent blood testing, as long as that is done, that will completely control all the symptoms because the levels will become quite normal.
Yeah, and like you said, people with autoimmune hyperthyroidism, it's much trickier because some people are just horribly hyperthyroid and they need huge doses and they need much more frequent checks. And some people just need a tiny dose and they're good for a while, and maybe sometimes they don't even need it at all and they kind of go into remission for a bit. So there's a huge kind of variability there for some folks. Um, Okay. Anything else you want to add to that at all?
Well, as we both implied, this is annoying to say the least. Certainly for the patient,
Right.
for us, it's somewhat straightforward as long as the testing is done. And sometimes we check blood levels even in 2 weeks if there's a big change in the treatment dose or something like that. One more thing to say about it is that about 1 in 5 people develop an allergy or have an allergy to these medications, and that can be tricky. Typically, people get hives, and so that it doesn't leave much. There's some significant cross reactivity. So if you have hives to one, you can get hives to the other. And as we just said, it's not straightforward. And so there are what are called definitive treatments for Graves' hyperthyroidism, and basically both get rid of the thyroid. So that may seem a little drastic, but the concept is that you convert this very unstable, unpredictable, questionable long-term outcome process to a definite 100% stable, predictable long-term outcome, and that is no thyroid, and then therefore hypothyroidism, and therefore lifelong thyroid hormone replacement therapy, which is much more straightforward once somebody's stabilized on thyroid hormone. they will typically need a blood test a year or something like that, and they feel well. So, the important thing to emphasize, this is almost always a personal choice. And many people, I'll never discuss this at the first visit because, as I said, it's hard for people to even think. And so what I'll often do at the first visit is just discuss the basic issues of what's going on and the basic treatment, ask them to come back in a month. And even then, we typically don't make any decisions. But some people will intuitively or personal preference choose something to get rid of the thyroid very early, just because they don't like the idea of the frequent blood tests and the long-term fussing around and the uncertainty. As you said, this disease can remit, can go away, but the odds are it will come back again at some point in the future. And other people absolutely don't like the idea of getting rid of some organ in the body that obviously they were born with. And they continue to prefer to use a medication like methimazole sometimes for decades. In the rest of the world, the methimazole, the anti-thyroid medications, are almost always the only treatment used. And the medical systems don't offer very often the option of getting rid of the thyroid. Again, it's a very reasonable option. Many people with Graves' disease do choose it, and outcomes are very, very good. And so I think it's a very reasonable option, but it is a personal preference. And people often ask me, what would I do? And I actually, this is one case where I don't tell them, because my personal preferences cannot possibly be their personal preferences. So when people ask that question, what would you do? Sometimes that's a reasonable question to answer just because it summarizes the way of looking at something. But in this case, really each person has to choose. Now, many endocrinologists will not offer the getting rid of the thyroid early on. And many patients actually then will choose to kind of string things out, see how it goes. Very, very reasonable. And that's why many endocrinologists don't offer it. I offer it early just because I think it's the patient's choice. But many will then choose, well, I'm going to do this for a while, 6 months, a year, 2 years, whatever. See how stable things are, see how annoying things are. If this goes really well, why have surgery? Why get rid of the thyroid? But if it really is very challenging, then yeah, that would make great sense. And that's a very, very good way of looking at it and thinking about it. Now, there are two ways of getting rid of the thyroid. One is surgery, which is reasonably straightforward. It's important to prepare the patient for the surgery with the medications to really suppress, to make the levels normal, which is safer for surgery. And the other one is something called radioactive iodine. Now, this is a quirk of history, right? Nobody would probably now even think about putting a dose of radioactive iodine in the body to achieve something. But this came out of a time in the 1950s, maybe even before that, where we were pretty free with radiation. People used to take x-rays of feet to fit shoes and that kind of thing. We really didn't have a sense of how dangerous radiation could be. So the radioactive iodine is a quirk of history. It's that old. And the advantage of it being that old is that we have literally hundreds and hundreds of thousands of people who have been treated this way, and can say with great confidence that the risk of any kind of risk is essentially zero, cannot be measured. If there is a risk, it's too small to measure. So the obvious risk one would worry about is causing some other kind of cancer or something like that, and it just simply is not there. The doses that we use are very small. Most of it, all of it, goes to the thyroid, and it painlessly just makes the thyroid disappear. People often ask me, well, where does it go? And the way I think to think about it is if you bruise your leg and you have a really big bruise in your thigh, big black and blue mark, that is a lot of blood just sitting there in the muscle, under the skin, and so forth. And the body, but those blood cells are no longer functional, and the body just simply removes them. That's another function of the immune system. So when you destroy the thyroid with radioactive iodine, it is simply removed, mopped up by the body. Very straightforward thing to do, even though intuitively it seems kind of weird. and we do it a lot.
Yeah, we certainly do. And most people tend to do very well after they have that and they get stabilized on thyroid hormone. As Dr. Ulbrecht mentioned, obviously, if you have one of these things done, you're not going to have a thyroid anymore, or at least a functional thyroid. So you will inherently require some thyroid hormone replacement to replace what you're not getting anymore. Okay, so moving into the last kind of umbrella branch of hyperthyroidism, and now that I'm saying that, we should probably after this touch upon just a little bit medications like amiodarone that do cause thyroid problems too. So we'll go into autonomous functioning thyroid nodules, toxic quote unquote nodules that cause hyperthyroidism. Do you want to briefly just touch on the pathology, the pathophysiology on that and whatnot?
Sure. So people with autoimmune function, so called, and we'll talk about what that means, are almost never symptomatic, and this is because this is incredibly slowly progressive. And the way to think about it, I'm sure we'll have an episode on thyroid nodules, but because they're incredibly common, at least if you conclude that somebody's actually listening to us. But if we have an episode on thyroid nodules, we'll talk about how common they are. And basically, a thyroid nodule is a benign tumor. It is a growth, an uncontrolled growth of cells and nodules anywhere. A little bump on your skin would be the same idea. And they're incredibly common in the thyroid. And anything that has sort of independent growth, independent existence, so to speak, can develop a mutation that's a functional mutation. And so some of these nodules, and it's a tiny minority, I don't know, I don't want to guess how it is, but it's very rare for us to see what's autonomously functioning thyroid nodules. But it does happen. It's a mutation within this benign tumor where the cells just lose the ability to be controlled by the feedback loops, and they just make thyroid hormone. They don't do it very well. They do it in small amounts. As the nodule grows and makes thyroid hormone, the rest of the thyroid becomes suppressed because it doesn't have to do anything. And eventually the levels can be high enough to be abnormal. And as we've been discussing, the TSH becomes suppressed. But at that point, it's so close to still being normal that, again, people are typically asymptomatic. Occasionally, we'll see people who are symptomatic, and it's either because it's been there and not noticed for some time, so it continues to progress, or there's something else going on. And in medicine, we always run into things that just don't quite fit the pattern, but that would be the typical pattern, asymptomatic. Now, it is also possible, and this is more common, to have multiple nodules in the thyroid for, again, reasons that we don't really understand. The term used will be multinodular goiter, and a goiter, the word goiter means enlarged thyroid, that's all it means. And multinodular means that there would be a lot of nodules in the thyroid. It is something that's very common in areas that have low iodine in the diet, because there the thyroid struggles to make thyroid hormone and is stimulated continuously to try and do that, and that stimulation can cause nodules. Why we see multinodular goiters in the U.S. where iodine is in salt and so on, I don't think I can tell you. But this is, again, something that's a little bit more common, and the presentation is exactly the same. The person becomes very, very slowly, often over decades, mildly hyperthyroid. And then, so if you look back at the levels, you can see 10, 15 years of the levels getting higher and higher, the TSH getting lower and lower to the point of overactive. In the case of the single nodules, surgery is often a good choice that people choose because typically this would be in younger people in their 40s, 50s. The multinodular goiters are often seen in people in their 80s, 90s. And then the anti-thyroid medications are a good choice, the same medications that we discussed for Graves' hyperthyroidism. Also, however, the radioactive iodine is an option for both types of patients. Um, so rare, but we do see it.
Right. Yeah, and the pathophysiology of that is actually pretty interesting. Most of the mutations, it's a G protein mutation, which, if people don't know what that is, we were talking about receptors earlier. You think about the receptor as a it's a protein that acts as a recipient for something to stimulate it and send the signal transduction through the cell. Um, a G protein has many components, other proteins part of it that act to kind of send the signal. And when TSH binds to, TSH receptor, it causes the receptor to change in shape, and then the cascade kind of begins. But in this instance, most of the time, it's one of the subunits is actually already tweaked into the conformation or shape that is the active form. So it is almost like it's being slightly stimulated just all of the time, which is why you kind of see the steady progression of levels getting higher and higher over time. Okay, anything else you want to add to that?
No, I think we covered hyperthyroidism pretty well, except in the special situations, and the most special situation is pregnancy.
Mm-hmm.
And I know that was actually on the list that you sent me, which is how I knew to talk about it. So thank you for the list. Um, so first of all, it is preferred not to deal with hyperthyroidism during pregnancy, i.e., one of the possible reasons for choosing surgery for Graves' disease, for Graves' hyperthyroidism, is intention to become pregnant, because treating Graves' hyperthyroidism during pregnancy, again, there are some challenges to that. However, it happens, or a person chooses to, maybe they have hyperthyroidism 3-4 years earlier. It resolves, as we talked about. It can. Now they become pregnant. Now it comes back. It has to be dealt with, and it certainly can be very, very well. But again, it requires very, very frequent monitoring. Early on in pregnancy, we don't use methimazole because it can cause, we think, very minor but nevertheless birth defects. So in the first trimester, we tend to use PTU. These are the same two medications I'd already mentioned. I'm not going to get into it, but the PTU has some other problems, so we don't want to use it too long. And then methimazole can be used for the rest of pregnancy and does not seem to cause any problems during the rest of pregnancy. So it's not it certainly can be managed. It has to be done quite carefully. We don't want to overtreat. Hypothyroidism, getting the thyroid level to be too low, so it can cause problems to the child. So we don't want to go there. Undertreated hyperthyroidism can cause major problems during labor. So it's really important to get the levels to be perfect during pregnancy. Again, not something that's all that challenging for us, but it has to be done quite carefully.
Right. And like I mentioned just not too long ago, certain medications actually can cause hyperthyroidism as well. Most commonly, something called amiodarone, which is a drug often used as an antiarrhythmic. It does have some iodine in it, and it can tend to mess with the thyroid cells, which can cause both under and overactive thyroid disease. Which tends to respond a bit better to kind of, well, you can have two types of it. Do you want to go into AT type 1 and type 2? Just a touch?
Sure. Could do. I mean, I think by the time you get to something that specialized, you just need to
Just
be
refer,
treated by somebody who knows how to do that. But it's interesting, actually, to your point, right? So the iodine in amiodarone can cause three things. It can cause hypothyroidism. It can cause productive hyperthyroidism, so-called type 1 amiodarone-induced thyrotoxicosis. And it can cause destructive hyperthyroidism, as we were discussing. And differentiating the two can be really tricky because of all the iodine. None of the tests quite work in that situation. So, but again, very manageable. as long as you know what you're doing. So not something to fear. A point that you made earlier, which I think is really important, and this is going way back to the beginning, atrial fibrillation. So atrial fibrillation, everybody knows about it now, right? It's in the news, AFib. And importantly so, because it can cause a variety of problems, including a person not feeling well and stroke. This is a very common and very concerning complication of hyperthyroidism as we get older, right? So I mentioned apathetic hyperthyroidism, and I should have put in there that in that situation, atrial fibrillation is very, very common and quite important to manage. Our cardiology colleagues manage that, but it's a really important reason to treat even relatively mild hyperthyroidism as people get older. I don't know how I got into that. I guess the arrhythmia piece of the amiodarone, but important.
Right. Okay. I just have thyroid storm on there, which we don't really ever see ever, but if you just want to briefly touch on that, because I think it is important, obviously, to know it, because it can be it is life-threatening for sure if it's not addressed.
Yeah, so you're right. Fortunately, we don't see it very often. We don't see it very often because on the outpatient side, certainly it's an inpatient problem primarily. But it's extreme hyperthyroidism. So if you think about all the symptoms of hyperthyroidism that we were talking about earlier, the big ones really. It's to call it thyroid storm, and at that point, it is life-threatening. The body's basically falling apart. The body's basically failing to be able to keep up with that drive of the extremely high thyroid levels. That's basically what's happening. And so at the level of the brain, you can go on to confusion, and people can become delirious, confused, kind of out of it. At the level of the heart, you can have heart failure. The heart can basically be unable to keep up with what the thyroid levels are driving it to do. And at that systemic level, you can start getting fevers where the body just can't manage that incredible drive. And those are the main hallmarks. There are check boxes, categories you can use to say that somebody is in thyroid storm if they meet two of these and three of those. That's a way of defining it. But most importantly, by the time a person starts being confused, starts having fever, starts having heart failure, those kinds of things, they're sick, and you absolutely can die, and people do die from thyroid storm. It's something that is, I don't say diagnosed, but a lot of people leave ERs, leave hospitals with the understanding that they had thyroid storm. At some level, that's not a bad thing, right? It emphasizes that this can be serious, can be important, can cause, can be life-threatening.
Mm-hmm.
As I think you said, I think the term is thrown around a little bit too much, and this is overdiagnosed. But in a sense, it doesn't matter, because recognizing that this can be life-threatening is the key piece of the puzzle. For those of us who are listening to us who will now start worrying about going into thyroid storm, it does not happen. Well, it's important. It does not happen quickly, and it almost certainly will not happen if the hyperthyroidism is treated and even reasonably well controlled. It's going to happen if it's not treated. If you have chosen to not treat, and there are people who do that. If you've chosen not to be treated for Graves, it almost always is going to be Graves hyperthyroidism, and then superimpose some illness, whether that be a viral illness or pneumonia or a car accident or surgery. It's that extra stress on the body that will often tip it. So you don't have to worry about going into thyroid storm. If you've been diagnosed with Graves hyperthyroidism and a hyperthyroid are being treated, it's not going to happen. But if somehow you stop treatment or don't treat, yeah, it's a thing. Absolutely, it's a thing.
Absolutely. Um, Anything else you want to add to hyperthyroidism at all?
I don't know that I do. As we did in episode one, the conclusion is that it's simple until it's not. And I think that is the case in thyroid disease in general. Um, it can all be treated. We have to make the right diagnoses and offer the right treatments, but it's all very manageable.
Absolutely. Anything else you want to add in general?
I don't think so, except to thank you for setting this up for us.
Yes,
I always enjoy these
absolutely.
chats and hope there are
Absolutely.
some people out there who appreciate what we said.
Yeah, the three or four of you out there that are listening and appreciate this. Like I said, the feedback on the first episode was very much appreciated. I know that Dr. Ulbrecht and I appreciate the kind words and whatnot. We're hoping to keep doing this. We don't have a set schedule, but we will continue to do topics. Maybe next time I'll put a poll out. I know we'll kind of laugh at this. So I have gotten a couple of people messaging me about male hypogonadism and testosterone replacement. So maybe we'll just talk about that because that's a really, really, really big problem. And there's a lot of misinformation out there right now on that specifically. But anyways, thank you, Dr. Albrecht, Jan. Appreciate your time as always. I think this was a good chat. Like we were saying earlier, hyperthyroidism a bit more comprehensive than hypothyroidism, just because it's a little more pieces moving in the puzzle. But yeah, anything else on any other ending remarks or anything?
I think we're good. Enjoy the rest of your day.
Okay. All right. Well, thank you. If you did end up listening to this whole thing, it was just over an hour. That's a long time to listen to us talk. So hopefully you're not sick of us by now, but thanks for listening. And that is the conclusion.